Good evening, one and all present here. I am Suchira from Science Integra, and I welcome you all for the 8th webinar of Maha Smiles Cleft Care for Every Child. I would like to introduce Dr. Charvi, who is the Program Officer of Smile Train India. Over to you, Ms. Charvi.
Thank you, Suchira. Smile Train is world's largest cleft NGO, and we have partnered in India with around 125 hospitals. And in the last 25 years, we have provided more than 7 lakh surgeries. We have been in collaboration with Fogsy since 2019, and here we have been doing a Maha Smiles flagship CSR collaboration with the help of Bajaj Finserv. The aim is to create awareness about the importance of timely treatment and timelines of cleft treatment, and build a referral network so that children can avail care from birth itself. Next slide, Sushila. So we have around 11 free treatment centers in Maharashtra across 10 cities. And we would request you all to refer if you find any cleft children, please refer him to the nearest Smile Trend Center. You can also suggest them to call our toll-free cleft helpline number, which is 1800-103-8301. I repeat, 1800-103-8301. So that's all from my side. I would now hand over to Dr. Rashmi. Her CV, please.
Thank you, Shabi ma'am. This is Amog's Maha Smile Trends 8th webinar episode. And we are very much thankful to Amog's President, respected Dr. Kuttakoti sir, and Secretary Dr. Bipin Pandit sir. They have provided us a very good platform. And we are trying to reach to each and every society of Maharashtra. And we are trying to create awareness about cleft palate and cleft lip amongst the gynecologists and obstetricians of Maharashtra. So thank you, Smile Train. We are very thankful to Dr. Parag Beniwale sir. He is our national coordinator, AMOX, and today he is the guest of honor for our webinar. I would like to introduce Dr. Parag Beniwale sir to the house. As we all know, sir is chairperson-elect of ICOG. He is a senior consultant, OBGYN, Pune. He is a PG teacher and unit head at Kamla Nehru Hospital. And he has been president of Menopause Society, Pune in 2018 to 22, and has been president of Pune Obstetrics and Gynae Society 2022 and 23. And we have all seen his tremendous exemplary work under his leadership. We welcome you, sir, and we would like to hear from you on this occasion.
Thank you, Rashmi, for those kind words. Good evening. I bring greetings from Pune, and it's indeed a pleasure to be sitting here with all of you attending the Maha Smiles program. This is the 8th episode, and I appreciate the efforts put in by the MOX office bearers, and of course Sujit and Rashmi as the conveners and coordinators for continuing this activity and trying to reach out to our members of MOX. The topics which we are going to discuss today are definitely interesting. We are going to listen to two aspects. One is the obstetrician aspect, which will be dealt with by Dr. Sanklecha from Nasik, who will talk about the immediate postnatal care in babies with who have cleft lip and cleft palate. And of course, we will also get to hear about the overview of management on how, when, and why from Dr. Bharati Khandekar. So congratulations to the entire team for arranging this. Of course, thank you Science Integra for being our academic partner. And I look forward to a very interesting learning session for all of us. Thank you very much.
Thank you very much, sir. Thank you for all the kind words, and you are really a friend in need for all of us, Amoxians. Thank you, sir. So we would like to move towards the scientific session, and our first speaker is Dr. Bharati Khandekar, madam. And I would like to introduce Madam to the House. Over to you, Sujit sir.
Yeah. I'm very much delighted to introduce and welcome Dr. Bharti Khandekar ma'am. She has completed her graduation and post-graduation in general surgery from Grant Medical College, Mumbai. She has done her MCH and DNB in plastic surgery from Nair Hospital, Mumbai. She has worked as first Smile Train Fellow at BJ Wadi Hospital, Mumbai. She has done visiting scholarship at Changgung Memorial Hospital, Taiwan. Since then, she is in private practice since last 25 years. And currently, she is working as a Smile Train project director at Mira NX Hospital, Ulhasnagar. Over to you, ma'am.
Can you hear?
Yes, ma'am, we can hear you.
You can hear me?
Yes, ma'am, you're
You
audible.
can hear. Yeah. I will just start my presentation. Can you see the screen now?
Yes, ma'am.
Just 1 second. Yeah. First of all, good evening, and thanks a lot for your introduction. I'm very grateful, and really it is always an honor to be associated with a Smile Train program. And this is my talk mainly on overall management of cleft lip and palate. Now, birth of a child always brings happiness, dreams, lots of hopes, and future to the family. And when after 9 months of pregnancy, when you see a child with a deformity, and specifically a deformity which you cannot hide, and which is very obvious, it is always a shock for the family and a hidden guilt most of the time for the parents to begin with. Now, I know that whatever few things which I will be discussing must have been already seen, but those I have found it relevant, hence I am repeating it. There are different types of clefts. The types of clefts here, which you can see on the screen, are on one-sided, that is unilateral clefts. The first one is the incomplete cleft, where the nose is not involved. The second one is involving the nose, which we call it as complete cleft, but the palate is normal. And now down, if you see, it is a severe kind of cleft deformity, where if there is cleft of lip also and the cleft of the palate also. Now, this classification is important for one reason, because the issues regarding the feeding and number of surgeries all will differ as per the type of cleft. Now, the cleft can be on both the sides. In the first case, if you see, it will be only involving the lip part. In the second, it is both lip as well as palate. And down, if you see, it is a very kind of bilateral cleft lip deformity, where you can see the protruding premaxilla or the central portion of the maxilla. And this is somewhere, as a team, we can definitely improve if the child is referred at an earlier age, which I will discuss as the presentation goes. Now, the cleft palate can be an isolated one, which you can see it on the left side. And on the right, if you see, it is associated with lip. Now, what is the difference between, what is the importance of having this classification is basically most of the times those children which are having only isolated cleft palate, as it is not an obvious deformity, most of the times the patients are referred very late and they actually miss the golden period. When it is associated with lip, it is usually referred to us at quite an earlier stage. Now, there are a lot of challenges. Now, the challenges are both technical challenges as a plastic surgeon or as a cleft surgeon, which I may not be discussing it in so much in detail because it is not relevant for the topic. But definitely that is the issue where, as a team, we can definitely give the best results if we refer the child at an early stage. Now, what are the other challenges? The commonest challenges are the malnutrition. The child is referred to us late when the breastfeeding has already been stopped because there is technical difficulty in feeding. So most of the time, the children are on the formula fed. So malnutrition, anemia are the main reasons why the patient's surgery gets delayed. The second challenge is multiple surgeries. The third challenge is if one practitioner would like to treat this deformity, it is not going to help the child as a whole, because it requires a team approach. It requires everybody's efforts. Then only you can get the best results. Now, I've been working in 3 smile centers up till now. First in a very well-known children's hospital, then at Godrej Hospital, which was a private hospital, and now I am at Ulhasnagar, which is very close to the patients, but the patients which are mainly from remote areas. The remote areas have their own problems. Like there is very less access to the medical facilities. There is no knowledge about immunization, the poor hygiene, poverty. The parents are not having any fixed income, illiteracy, and all because of all these things, actually you have to reach the patient. Patients very few of the times will come to you. And another thing is you have to plan everything in such a way that the number of visits to the hospital will be reduced. I'm audible to everyone? Hello?
Yeah.
I'm audible to everyone?
Yes,
Yes,
ma'am.
ma'am. Yes, ma'am.
Now, what are the current changes? I must have seen these cleft patients for about 24 years to 25 years. And the trends which have changed now, previously when I was attached to the hospitals, that time usually these lip cases used to get operated in camps, because that was yearly camps used to be there. And they were without much of fitness problems, they were operated for lip surgeries. So that time the patients which were having a palate are never operated in a camp. So we used to get a lot of adult palate cases. Now if you see above, a female who I have operated at the age of 39 years. Fortunately, this has become rarity. That is because of the awareness by the Smile Train, awareness of the media. There are many Smile Train centers, and now we have come to a stage where we are getting antenatal references. And this is something which is very important for 2 reasons. One reason is we can give emotional support to the family at the earliest. The second thing is I plan with my coordinator visit to the hospital at an earlier stage where the feeding issues can be handled at earlier. Now, if you see in the down photograph in which there was one child which was referred, was sent to us during antenatal period with a sonography report. Moment the child is born, me and my coordinator, we met the concerned people. Now, what are our aims and objectives when the child is referred in antenatal period? The first thing is the emotional support to the family, because this is something very shocking for them. The second thing is we would like to know whether there are any other like neurological issues or the prognosis or the course of the treatment. That is the second thing. Third thing, the parent should be told that it is a correctable deformity and there is no financial burden. That is something which always gives them a lot of relief. Another thing is malnutrition, which we find is a major reason because of which the surgeries get delayed. So importance of early execution of breastfeeding, we share the videos with them. Our nutritionist, our lactation counseling nurse, they always discuss with the parents how the things should be done. And very important thing is reference to a Smile Train center. Why this is important? I have also come from municipal government hospitals where there all the departments are there, but unfortunately they are loaded with so many different problems. So concentrating on one problem, giving a comprehensive cleft care, changing the resident, all these things, lastly compromise the result of the child. So I think the early reference to a Smile Train is very much necessary. Now, I'm just giving you a roadmap of surgical and non-surgical methods from the day the child is born till the last surgery. Now, when the child first comes to me, what first means he has not been seen in antenatal in the postnatal period, and it comes to my center, I see to it that it has been seen by all the consultants. First, the pediatrician evaluates the child's other congenital anomalies. Then the nutritionist sees the severity of the malnutrition and whether the nutrition and the respiratory status, means what is the respiration at the time of nutrition, whether the child requires any observation in the hospital or any admission in the hospital. And once that has been done, simultaneously I will grade the severity of the cleft. And after grading the severity of the cleft, usually I tell the parents about the plan. After that, there are many other children who have been already operated in the OPD. So they get some amount of a support, the parents, because they know that they are not the only one who are facing the deformity, and which helps them a lot. Then coming to the first month after birth is also they are seen by the orthodontist. I always usually see whether it is suitable for NAN. Now here comes the thing, what I have discussed previously about the technical challenges. Now, if you see in these cases, if the child is referred to me immediately after birth, and if it is suitable for NAN or nasoalveolar molding, we can get very good results. Now, in first case, if you see, it is a unilateral cleft lip with palate. In the first photograph, the gap is quite big. With the nasoalveolar molding, the gap is reduced. And in the third photo, if you see, it is a stability of the nasal result after 1 year. The maximum advantage which I get is in cases of bilateral lip and palate, which you can see is a second case, where the central portion of the maxilla, or what we call it as a premaxilla, is so much protruding that it is very difficult to get it center. They will not remain like that. So there is no backward pull for the premaxilla, and premaxilla remains in the same situation many times. So this is one thing where if the child is referred to us immediately after birth, we can plan orthodontic workup and can do a first dental impression at around 2 weeks. Usually, I plan it somewhere in our hospital also when the anesthetist is around to avoid any other problems. Now then, the next visit is planned after a period of about a month, where the child is again seen in terms of nutritional status. The orthodontist always tell them regarding maintenance of dental hygiene that the alveolus has to be cleaned with a clean, soft cloth at least 2 times a day, morning and night. And around 3 months, if the child is nutrition-wise okay, and if it is clinically fit for anesthesia, and pediatrician's fitness is there, I always tell my anesthetist to see the child in view of lip surgery. Now the child, once fit, will be posted for surgery at the age of 3 months. Now, I would like to share few of my results because I think that will tell you that it is absolutely correctable deformity and the child will look like a normal child. This is the incomplete lip. This is the result in cases of complete lip. This is in cases of severe form of complete cleft lip and palate. In all these 3 cases, I have not done nasoalveolar molding. These have come late to me. This is a bilateral one. You can see the result. The children are quite normal. This is again another case of bilateral lip and palate. Now coming to palate, at somewhere around, this is a very important time frame when the children to be operated between 9 months to 18 months period. This is a very golden period, then you get the best results. And usually the minimum time gap between the lip and the palate or any surgery should be at least 3 months. Now on the left, you can see the isolated, on the right is the along with the lip. Now how we evaluate the success of the palate surgery? Now the success of the palate surgery is a good speech. I would just like to run a just audio which has been of one of my patient who is operated for a palate. She is not a Marathi, but speaking a Marathi, singing a Marathi song. So there might be some pronunciational issues. So you can have a speech. very important surgery, palate surgery. Though, because it is not just plugging the hole or it is not just closing the hole. You need to, it is a very complicated procedure. You need to give a lot of details about this surgery and a very good speech therapy. All these things can give you a very good result. Now, when this child is after surgery, usually the parents are counseled, means after 3 months, before palate surgery, the parents are counseled by the speech therapist. Now, what are the aims and objectives in this case? Mainly the language stimulation. Still 3 years of age, the articulation therapy doesn't start. So during this language stimulation, if you see, there is always in these children some kind of speech delay. Here, during this therapy session, the parents have been told about the speech milestones. Then what you exactly mean by language stimulation? Nowadays, if you say there is a poor communication between parents and child because of this deformity, with few of the times allowed to play with other children. So there is a less communication with their other children also. There is an excessive screen time. So all these things give rise to problem for language stimulation, which is a major thing in this speech therapy. Now, what we advise usually to the parents regarding communicate with the child in regular activities where you are either feeding them or giving a bath, talk to them, communicate with them, allow them to play with other children, involve them with different talks, and avoid baby talk because they usually mimic the same talk, and carry a diary with child's speech patterns. So that what happens when the child has come to a speech therapist, the time is not wasted in trying to find out what are the problems. You come with the problem and the solutions will be given. Now, then between 3 years to 6 years, actually there is no major surgery. The surgery between 3 years to 6 years, usually if there is a palatal fistula, if there is lip revision, sometimes these children, they fall, or there is a wound dehiscence, or there is a palatal dehiscence, if the nasal correction is required in cases of severe deformities, these are only surgeries that are required during 3 years to 6 years. The main objective in this period is articulation therapy or the speech therapy. So the speech therapy usually concentrates on the child developing an intelligible speech. So if everything goes fine, in about 1.5 to 2 years, the child attains a good speech. This period is also utilized for dental hygiene, because we need to prepare the child for alveolar bone grafting. So for that, dental hygiene is required. Now, somewhere at around 7 years, I again refer the child to the orthodontist. Can you hear me properly? Can you hear me?
Yes, ma'am. Yes, ma'am. Yeah.
Yes, ma'am, we can hear you.
You can. So now, somewhere around 7 years, the child is referred to the orthodontist. And if you see, these are the alveolar case. The cleft is the dental arch. On the left, it is a unilateral one. On the right, it is a bilateral case. I have put both the figures because in cases of one-sided cleft, only one alveolar bone grafting will be required. And when the cleft on both the sides, the alveolar bone grafting will be required in both the sides. So one more surgery. Can you hear me?
Yes, ma'am.
Yeah. So after dental alignment, we plan for a alveolar bone grafting and the closure of the oronasal fistula. The cancellous bone graft is harvested from the iliac crest and the cleft is closed. And again, after 6 months, refer to orthodontist for further management. Now then comes again the orthodontist picture. If the skeletal deformity is not severe, if you on the left side, if you see that there is not very much, maxilla is not that much retruded. And on the right side, it is severely retruded. So the first case we can manage with only orthodontic treatment, but in second case, we require is both orthodontic as well as orthognathic surgery. So this is the last surgery for the skeletal platform. And after that comes a last surgery, which we call it as a nose reshaping or rhinoplasty. This is the last surgery in case of a child. Actually, child will be there from the birth to 18 years of age. Usually, ideally, after skeletal correction, you should undergo a rhinoplasty. But most of the times this doesn't happen because these females, they come to in the marriageable age, want some quick results. They don't want to have a pre-surgical orthodontics, orthognathic surgery, a period of 2.5 years. So in these cases, a rhinoplasty is planned and the deviated nose can be totally corrected. And this will be the last surgery for the child. After seeing all these things, I'm quite sure that it is, if you want to have a best results, it is always necessary to have a comprehensive cleft care. One thing. Second thing is at the earliest referral, so that there will be timely surgeries, there will be proper coordination with everyone, and we can achieve the best results. Thanks everyone. Yeah. Thank you.
Thank you very much, madam. That was a very elaborative and informative talk. If Dr. Parag Bidimale sir is here, we would like to take opinion from him.
I have not heard. Can you just please speak?
Thank you so much, Bharti ma'am. It was a very elaborative and informative talk. Thank you for all the inputs.
Yeah.
And Suchira, if you have any questions in chat box, please let us know.
Yes, ma'am. Will I address these questions at the end? Is it fine?
Yeah, okay.
Okay, ma'am. Thank you, ma'am.
Bharti madam, one thing we have been doing these webinars, and one new thing we learned today, and it was about the nasoalveolar molding. So can you please throw some more light on this procedure?
Yeah, it is a non-surgical method, and here there is a plate which is given. It is done by orthodontist, and it is done ideally somewhere at around 2 weeks when everything is moldable, and with the use of splints, means the plate and extension in the nose. It is the whole shape is maintained and the gap is reduced. And in cases of bilateral lip, usually the maxilla, premaxilla, which is protruding, is taken back. So it is a non-surgical method done by the orthodontist. The important thing is the time. Because after about 1 month, the things are not moldable. You will not get the desired result. And it actually gives you a very comfortable atmosphere at the time of surgery.
Thank you, madam. I would like to know, ma'am, like, is there any decrease in the cases, prevalence of cases in your practice? Because you have been looking after this patient since last so many years.
No, actually, I can tell you one thing. The number of patients coming to the center are not less. They are actually increased, maybe because of awareness, and now unoperated clefts are very less. So maybe because of that. And another thing is, previously I have not seen so many cases and where they refer to me in antenatal period. Now it has come in antenatal references are increased, but the number is not at all decreased. Maybe one more thing is there, that all the cases are now diverted to the center, not distributed in different hospitals. So maybe because of that, that is one more thing. If we work together, we can have a registry, which will actually tell us about the incidence part. Previously, everything was distributed in all the municipal hospitals, government hospital, surgical camps. Now they have been directed to Smile Train centers. So maybe the incidence in those places, they might consider that is decreased, but I don't find there is any decrease in the number. But unoperated clefts are less. Unoperated adult clefts are very less.
Because of good imaging now, with the advent of newer sonography machines with good resolution, most of the diagnosis has been done before birth in antenatal period. The adult group is very rare, I think now.
Yeah, adult group is very rare.
Yeah. Because the parents know beforehand that the babies are having such and such deformities.
And one more thing is there. See, when there is a financial burden, आपण म्हणतो ना पैशाचं सोंग आणता येत नाही. And when there are multiple surgeries and when the financial burden is not there, you are going to take the help. Otherwise, each and every parent would like to have their child to be treated. The constraint is always the money.
Right, ma'am.
Thank you so much, Bharti madam. It was really very nice to have you with us today. Thank you, madam.
Yeah.
We would like to move to our next section.
Ma'am, could you please stop the presentation?
Yeah.
Over to you, Sujit sir.
Yeah. So the second talk is from respected Chandrakant Sankleshwar sir. I am very much honored to introduce and welcome him for this webinar. He has done his MD FICOG practicing at Nashik since 1991, runs a private maternity home. He is honorary gynecologist at Nashik Municipal Corporation Maternity Homes from 1991 to 2016. He has special interest in high-risk pregnancy and operative obstetrics. She was past president IMA Nashik in 2008. She was past president of Nashik OBGYN Society from 2018 to 19, and he was organizing secretary West Zone of Oxy 2014. Over to you, sir.
Thank you, Sujit, for the introduction. I'll share my screen.
And Sujit sir is one of the key MOX persons. He's our Zodar coordinator.
Yeah. Start my, yeah. Can you see my screen? Yeah. Am I audible?
Yes, sir.
Yeah. So I'll be talking on immediate postnatal management in cleft lip and palate. First of all, thank you Smile Train family for inviting me to speak on this topic. I know they are doing wonderful job, and in Nashik also we have one Smile Train center. So just a minute, please. So incidence of cleft lip and cleft palate is about 1 in 700, that is 1.1 or 1.2 in 1000. So it is not very rare. We see it quite often, and more than half are non-syndromic. Almost more than 70% of the cleft lip isolated are non-syndromic, so not associated with any other abnormalities. So the important thing is there is embryonic predisposition, genetic factor as well as environmental factors in the occurrence of this cleft lip and palate. And environmental factors which are adding to the risk are smoking and alcohol consumption in pregnancy. Whether any drug consumption during pregnancy is responsible is not yet proven. If there is family history of cleft lip, the chances are more. Now this development of cleft lip and palate, this takes place in embryonic stage only. So cleft palate isolated usually will occur at 5 to 12 weeks, and cleft lip plus palate will occur much early, 3 to 7 weeks. That means many times before the pregnancy is even being diagnosed. Cleft lip and palate, boys are more predisposed than girls, and left side, if it is unilateral, is more common than right. Whereas in cleft palate, it is the other way around. Diagnosis, as it was told that nowadays many times it is diagnosed on ultrasound quite early in pregnancy, early second trimester you diagnose. The problem is, as this is not a life-threatening abnormality, you have to continue the pregnancy, and many times patients are quite anxious because they know that their kid has cleft lip or sometimes cleft palate. Cleft palate is many times very difficult to diagnose by ultrasound, but cleft lips are diagnosed very easily. So at birth, thorough examination of the child is very important. Now, cleft lips sometimes involves upper gum or alveolus. Khandekar madam just now showed us very good photographs of complete cleft lip and incomplete cleft lip. Complete is when it is all the way up to the nostril, and if it falls short of the nose, it is incomplete. It can be unilateral or bilateral. So as you can see in this figure, the left one
The slides are not moving.
is... Yes,
The slides are not moving.
now
On screen, there is first slide, incidence and risk factors. Now, yeah, next one, sir, please. Yeah, this is diagnosis. Yes.
okay,
Yeah, now, yeah.
I'll keep it like this.
Yes, sir.
Okay, so if as you can see in this picture, the left one shows incomplete unilateral cleft lip. The middle one is complete unilateral cleft lip, and the right one is bilateral one. So there are many conditions that can be associated with cleft lip, and they are deformity of the nose, as we saw in many pictures that Dr. Khandekar showed us. Many times the cleft involves alveolus, and a further surgery is required. There can be missing teeth, there can be extra teeth, or misshapen or poorly formed teeth. So these are the conditions associated. Cleft palate also varies in appearance and severity. As we know, the palate is formed of two parts. One is hard palate and the other one is soft palate. So cleft can involve both the palates, like soft plus hard. Sometimes it is only in the region of soft palate. So it is missed very commonly, and for this a thorough examination at birth is required. There is something called submucous cleft palate, where the mucous membrane over the palate is intact, but there is cleft in the bony part. So many forms of cleft lip and palate. We saw all these things in the previous presentation. There is something called Pierre-Robin sequence, where there is micrognathia, that is mandible or lower jaw is small. So it pushes the tongue backwards and it causes airway obstruction. Also, it may work, it may act in the formation of cleft lip. Usually these babies have respiratory distress. So coming to our topic today, immediate postnatal concerns. The most important postnatal concern, as soon as the baby is born, nowadays many times we know beforehand only that the baby is going to have cleft lip. But even in today's world, there are surprises, and only after the birth of baby, we come to know that baby has a cleft lip. For cleft palate, you have to have a thorough examination of the palate. Feeding is the main concern. It's a huge concern for patients, and they have delay in growth because of difficult feeding. As madam told us, lip repair is recommended between the age of 3 and 6 months, and palate repair between 9 and 12 months. So you have to feed the baby for almost 3 months before lip repair can be done. And this is a big challenge. So what are the priorities for us? One is maintaining nutrition, finding a feeding technique as close to normal as possible, because normal feeding technique cannot be attained, but as close to it as possible. And the main underlying problem in these patients is failure to generate sufficient negative intraoral pressure during suction, because baby cannot form a firm grip with his lips on the breast. So the problems are, there is insufficient suction, there is excessive air intake because of the leakage, there can be choking, there can be nasal regurgitation because of the gap in the palate. Because baby has to put in lot of efforts, it gets fatigued early. There can be inadequate milk intake leading to failure to gain weight, and there is excessive time required to feed because there is difficulty in generating enough suction pressure. All this leads to maternal stress and anxiety, which in turn leads to poor mother and infant bonding. So what are the feeding methods for these patients? So immediate concern postnatal is feeding of these babies, and to train the mother for feeding and her attendant also. because alone, I don't think any mother can cope up with the feeding stress of these babies. So what are the feeding methods available to us? One is breastfeeding, the other is bottle feeding, third is spoon or cup feeding, or combination of these two. In bottle feeding or spoon or cup feeding, we can use mother's milk. Mother can express her milk and use it for bottle feeding. For all these feedings, correct positioning of the child is very important. So what are the instructions which we should be giving to the mother? We have to feed the baby often. Normally, in a normal baby, we ask the parents or the mother to feed the baby every 2.5 to 3 hours. Here, the frequency is much more. You have to feed often, at least 8 to 12 times every day. And feeding is not to be exhaustive. You have to limit the feeding time to less than 30 minutes because the baby gets exhausted by them. Burping, you have to do more often. Many times during the feed, you have to do burping 2 to 3 times because of aerophagia, because there is a gap in the lip, there is a gap in the palate, there is aerophagia and lot of air is sucked. So you have to do repeated frequent burping. If we are using spoon or cup feeding, if we are using bottle feeding, oral hygiene we have to maintain. If we are using prosthesis, if the gap is very big in the palate and you have to use prosthesis, then that gum pad and prosthesis needs to be cleaned very often, and sterilization of feeding bottles and nipples is observed very carefully. You need to reassure the patients. You have to reassure the mother. She needs to keep patience as the babies take longer time to feed. So in case of isolated cleft lip, what they call modified football method or straddle position is followed, where the baby is positioned with the cleft towards the breast. Cleft is facing upwards, and this allows the cleft to be tucked into the breast tissue. A mother can further support infant's cheek so that it will close on the breast and baby will be able to feed. So many times isolated cleft lip, the babies will be able to breastfeed properly. As you can see in this sketch, the correct position is to hold the baby in upright position and not horizontal position. There is something called dancer hand position, where the mother supports her breast with 3 fingers, and with thumb and the first finger, index finger, she forms a U with which she grips the baby's jaw and cheeks and presses the baby's mouth to the breast so that it helps the baby to have a firmer grip. Now bottle feeding. As we know, the position in bottle feeding, we have to keep the baby upright at 45 degrees. There are squeeze bottles. Hard bottles are of no use because baby cannot suck vigorously. We have to assist baby in feeding, and the bottle should be squeezable. So before using any bottle, the mother should be well versed with the softness of the bottle and how to squeeze the bottle and what amount of pressure will release how much milk. So there has to be earlier practice with the bottle before actually feeding the baby. Now you have to squeeze the bottle rhythmically only when the baby sucks so that it assists the baby in feeding. Usually a squeeze every 3 to 4 sucks is usually sufficient. Many times the baby sucks properly but gets exhausted very fast. So you have to assist the baby in it. You have to have several breaks for burping, as I had told. And you have to keep each feed for 20 to 30 minutes and not very long, because you have to feed the baby very frequently. You cannot keep each feed very long. In bottle feeding, you have to have a squeezable bottle, and the nipple should also have a cross opening for the easy flow of milk. In conclusion, feeding is the main challenge in postnatal period because we have to prepare the baby for surgery in 3 months. Baby needs to gain enough weight to sustain anesthesia and surgery by 3 months. Because of gap in the lip, baby cannot generate negative pressure and cannot apply suction. So we have to assist the baby in feeding. And for that, you have to train the mother in feeding the baby well. Now, especially in our country, there is lack of data which bottles are better, which squeezable bottles are better, and which method like cup feeding, spoon feeding, or bottle feeding is better than the other one. There is no enough data. Specially designed squeezable bottles are available where there is a wider nipple which can be gripped with the help of palate or alveolus. And proper counseling and training is actually needed in every case, because proper reassurance and support, mental support to the patient is very important. All the mothers need to be counseled that a baby with cleft palate requires almost thrice the time for feeding compared to a baby without cleft palate. This is very important. This is very frustrating sometimes and very difficult to continue this for days together, because palate surgery will take place at the age of 9 months. So you have to keep feeding the baby for 9 months and it becomes very difficult. So you have to teach the mother well. Otherwise, in case of regurgitation or otherwise, there can be aspiration and respiratory infections and pneumonia. Frequent burping is very important. So positioning of the baby, holding the baby's cheeks together, positioning of the baby, small duration feeds, frequent burping, and assisting the baby in feeding are the things which have to be looked after. Parallelly, you have to support the mother emotionally. So these are the challenges we faced in immediate postnatal period. Thank you.
That has been very nice, excellent, elaborate talk, sir. You have given full justice to the talk and subject. You have covered everything very meticulously, including various risk factors, diagnosis, associated conditions, various types of cleft lip and cleft palate, what are the immediate postnatal concerns, and various instructions to overcome them. And you have shown very good sketches about feeding positions. So that was a very wonderful, nice, very well covered talk. These are the very basic things which one need to know. Every parent need to know what to do when they are having such problems immediately after the delivery of such babies.
Thank you.
Thank you very much, sir. And sir, you are closely associated with and working with the patients of cleft lip and palate in your area. So please elaborate your experience about
See, my
general
experience
experience.
is, cleft lip is diagnosed very easily, but
Yeah.
even in I think last 10 years, I know at least 2 patients whom we missed cleft palate because the mother was feeding the baby well, and only after 1 month that the baby is not gaining weight, a thorough examination was done and cleft palate, partial cleft palate was diagnosed, and then we took all the precautions. So my appeal would be to actually examine every single baby very thoroughly for cleft palate especially. Second thing is, if you teach the mother well, see, first she has, it's a shock for her to see the baby, but she has to overcome that. So you have to counsel her well and you have to reassure her and give her mental support. And if you teach her well, mothers are very quick to learn these things, and they are actually very caring for their baby. So they are ready to, work overtime for the baby. And it's a matter of 3 months, especially in case of lip. So patients, yes, they do learn very quickly and follow all the instructions well. We have to avoid pneumonia and respiratory infections at any cost. That is very important. And we have to see that the baby gains weight. So growth chart, development chart, we have to tell them how to keep this chart. It is not very difficult. So if you teach them, my experience is they learn very fast.
One more thing I want to add here about prenatal diagnosis of this thing. Prenatal diagnosis of cleft lip and cleft palate. Cleft lip is easy. You can suspect it easily at around 14 weeks or so.
Yes.
But diagnosis of isolated cleft palate is very, very difficult. So you should include the uvula, equal to sign of uvula in the coronal section of the neck. You see the two lines equal to sign as a routine, as a must in your screening tool, in your each sonography. When the
At the
visit
time of anomaly scan, yes.
yeah, during anomaly scan. Even this sign can be seen at around 14 weeks also with good machines.
Okay.
And it should be as you use as a screening tool. And if you don't find it equal to sign, you have to look at the soft palate directly on a mid-size section with slightly extended view of the neck. And with some fluid in oropharynx, you can see the total soft palate till end. You can try it. It is very beautiful thing to look at.
Yeah.
In this way, you can make the diagnosis of cleft palate, isolated cleft palate very easily.
And so that you are prepared when the baby is born.
Yeah, everyone is prepared for that. You can counsel the parents accordingly. You can ask them to consult with pediatricians and all those things which are expected after delivery.
Yes.
Thank you very much, sir. As Suchira, the coordinator, she has informed us that we have around 302 people logged in for this webinar today, and they are actively logged in. So thank you very much to all the viewers.
There is a question for Parag, sir.
There is one question for Parag, sir, actually.
Yeah.
Me?
Audience.
Yes. Yeah.
Dr. Iyer, she has asked, like, she is working in an area, IT department, and there are many patients who are smokers, and she says that out of 5, two ladies are smokers, and she says that she has seen only 2 patients of cleft lip and palate, and she wants to know the association and how AMOX can help in making an awareness program about this.
I think it's the public awareness committee can do some activity as for all the addictions, including smoking, alcohol, even substance abuse is something which is so common. So now, in fact, we've started asking history of substance abuse because there are some youngsters who openly tell us that they do occasional use marijuana, etc. So I think we have to talk to them about impact of all these substances on OBGYN in general. And then, we can specifically touch upon conj anomalies where maybe Sujit, who's an expert in it, can make a presentation. And, we should be having a good module for public awareness with this.
Thank you very much, sir. And because yes, sir.
Actually, I think a public awareness committee can prepare one poster just mentioning that mother's smoking or alcohol consumption or substance consumption will affect her baby badly. Talk to your doctor. So in that case, the mother will be forthcoming to tell you that, yes, I smoke. So what are the possibilities and what precautions I should take? I think just to tell that it will affect your baby. That's all. So that she will only be concerned and she will. This can be done. Like
Maybe we can add few photographs of conj anomalies which Sujit provide. That will have a better impact, I suppose.
Yeah, visual impact is always better. Yes.
Yeah.
Yes, sir. Thank you very much. And sir, because we have been doing these webinars continuously, we have been thinking and we feel that we should, at amongst leadership, all of you should take cleft lip and cleft palate registry, so that we can have a good record of cases, and then we can do more work and research about it.
Right. In fact, when we had the first meeting with the Smile Train, this was when Dr. Nandita Panchetkar was president of Foxy. So she had invited me that time, as I was secretary of ICOG then, to be part of that discussion. So I still vividly remember that discussion which took place in 2019. And then these programs were initiated slowly.
Thank you very much,
These
sir.
episodes are very, the attendance is more than 300, 350 at each episode. Very nicely covered. Coverage is very good.
So thank you very much, all the respected dignitaries, and I would like to propose a vote of thanks. We are very much thankful to AMOX President, Dr. Kuttakoti sir, and Dr. Bipin Pandit sir, our National Coordinator, Dr. Parag Biniwal sir, to be the guest of honor today, and our zonal coordinator, Dr. Sankulicha sir, and speaker, Dr. Bharti, madam, for all the excellent talks, Dr. Sujit, Dr. immense efforts for making this program. Science Integra, Maha Smiles. Thank you very much. And last but not least, Suchira, who is taking painstaking efforts for making this webinar successful.
Thank you, ma'am. Thank you so much.
Thank you.